Hello, everyone. Thanks for joining me. I really appreciate your joining me today. I really know that all of you are very busy and sometimes hard to take time out of your daily responsibilities. So thanks Dr. Vijaya and Dr. Keerthana, Dr. Naveed and Dr. Sana. Regarding pre-meeting requirements, I don't know, but I feel that using the laptop and earphones or headphones will help you to listen and to concentrate more. Especially you'll have better control over your camera, your mic, and I think chatting will be easier. So that's why I wrote to use laptop and headphones. And again, sitting in isolated quiet room to get the best of this presentation. And as I posted, because this part is dependent on the previous part, so you already watch it because you were there. Whenever there is parts or sequence, we should follow these sequences. And in this part, we will add more details about the etiology. Here is the time frame here. First, we'll have the assignment, hopefully in the first 30 minutes. And again, I will go over the etiological factor in succession. Regarding the etiology, as Dr. Keerthana mentioned, there are actually three basic types or etiological factors for amblyopia: the refractive, strabismic, and vision deprivation. Because combined or mixed is basically the combination of the previous. And regarding the reverse amblyopia, it is a form of vision deprivation. But I like putting the etiological factors in this way because if we have like multiple headings, we pay attention more because sometimes our minds ignore subheadings. So if we have like big heading for mixed amblyopia, a big heading for reverse amblyopia, I think we'll not forget these two important forms of amblyopia, combined and reverse. Okay. And I found this mnemonic for the etiological factor for amblyopia in iWiki website. As you know, SOS or SOS is an abbreviation or like an acronym for Save Our Souls. It is an emergency call, but we can say Save Our Sight, and every letter stands for a cause. So the first S here reminds you by the spectacles, so it points to the refractive error. And here O for occlusion, because in vision deprivation amblyopia, we have an occlusion of the visual axis. And the last S here is for strabismus. So if you like, this is a nice mnemonic, so that's why I mentioned it here. All right, we assigned last time 4 participants, and we shall start by Dr. Keerthana. So are you ready? And kindly speak slowly, please.
Okay, so visual deprivation amblyopia actually it has got other names like stimulus deprivation amblyopia, visual stimulus deprivation amblyopia, or a form vision deprivation amblyopia. Okay, it's the least common type. It's the most severe, and it is the most difficult to treat. And the basic pathology is either a complete or partial obstruction of the visual axis, which is resulting in a degraded retinal image. So the causes include media opacities, which is a congenital or an early onset cataract, corneal opacities, infectious or non-infectious intraocular inflammation, ptosis, posterior segment causes like retinopathy of prematurity, optic nerve hypoplasia, and uveitis. And always in visual deprivation amblyopia, the unilateral obstruction of the visual axis tends to be worse than that produced by bilateral deprivation. In any amblyopia or in any squint, the unilateral is always worse when compared to that of the bilateral. And similarly, in children younger than 6 years of age, dense central cataracts are likely to cause more amblyopia than those lens opacities which appears after 6 years of age. And they also say the first 3 months of age is even more important, because whatever happens in the first 3 months of age is going to cause a permanent and a profound visual deprivation when compared to those which appears after 3 years. That's what I've mentioned in this one. So significant media opacities through the first 3 postnatal months produces profound and permanent reductions in visual acuity, and deprivation developing after 3 months of age can lead to less profound visual acuity. And it is not necessary that this deprivation has to be for longer period of time, even if it is a brief visual deprivation in infancy, and that is also enough to cause an amblyopia. And those cataracts which are removed and treated by optical correction by 2 months actually tend to have more better prognosis than not being treated. And similarly, unilateral cataracts are better treated by 6 weeks, and bilateral cataracts by 10 weeks maximum, not more than that. That's it, ma'am. Thank you.
Dr. Keerthana, thanks again for informative presentation. And now, Dr. Naveed.
Yeah, good evening, everyone. My topic is refractive amblyopia. So just coming to refractive amblyopia, this could be, it occurs mainly because of untreated unilateral or bilateral refractive errors. So the refractive amblyopia can be of 2 types. It is anisometropia or isoametropia. So this anisometropia is usually it causes unilateral amblyopia, and anisometropia can lead to unilateral amblyopia in 46 to 79% of the cases. And the odds of developing amblyopia are 1.5 to 40 times higher in case of anisometropia compared to isometropia. And what is anisometropia? Is nothing but there is a difference in the refractive power in both the eyes, or the one eye could be a normal, perfectly all right, and the other eye could have a refractive error, or both the eyes could have a refractive error. One is a milder form and the other eye could be a moderate or severe degree. So isoametropias that can lead to bilateral amblyopia. So it is a refractive error. There is the same refractive error in both eyes, which could be mild, moderate, or severe. Now coming to anisometropia, it causes unilateral amblyopia, and it develops when unequal refractive error causes the image on one eye, on the one retina, to be more poorly focused than in the fellow eye. So this anisometropia can occur in combination with strabismus also. So anisometropia amblyopia is thought to result partly from the direct effect of blurred image on the development of visual acuity in the involved eye, and partly from the intraocular competition or inhibition similar to that responsible for strabismic amblyopia. So the greater the degree of anisometropia or astigmatism result in increased risk and severity of amblyopia. So now coming to isoametropia, this leads to bilateral refractive amblyopia and is less common than the anisometropia, and occurs mainly because of bilateral reduction in visual acuity in both the eyes in the developmental age group. And it results from the effect of blurred retinal image alone on following the retina. I think this is what sums up my topic about refractive amblyopia.
Thank you so much, Dr. Naveed. Well done. So we finished the stimulus deprivation and refractive. And Dr. Sana, are you ready?
Good evening, everyone. So reverse amblyopia, it is the occlusion amblyopia. It is a specific form of deprivation amblyopia that may be seen after therapeutic patching or cycloplegia of the non-amblyopic eye. Now, we should know that this amblyopia is occurring actually in the normal eye during the course of treatment. So when we are actually treating during the course of treating the amblyopic eye, this reverse amblyopia occurs in the fellow eye. So either it can occur during the therapeutic occlusion therapy, which can be either by patching or by cycloplegia. So it is actually defined as having occurred when the visual acuity of the sound eye is 2 or 3 Snellens or logmar units worse than the visual acuity of the amblyopic eye after treatment. So what are the risk factors for this reverse amblyopia? So first of all, age, tender age, that is less than, if the child is of a younger age, a group that is less than 4 years of age, highly hyperopic patients, and those children who have dense strabismic amblyopia, and especially those who are having an occlusion therapy in the form of daily atropine. They appear to be at the most risk for developing this reverse amblyopia. So among strabismus also, those children who have large angle isotropia are the ones who are at high risk for developing reverse amblyopia, and lack of adherence to spectacle wear. So here I would just like to say that how atropine acts is like it causes cycloplegia and it prevents the accommodation and blurs the sound eye at near fixation. So the effect will be augmented if the sound eye is hyperopic. So it was observed in many studies that many children and even parents, they switched from patching to atropine, but none of the children switched from atropine to patching. This is because patching is like a social stigma for most of the parents and children. They consider like a social stigma, and the children are very much resilient to this, and also they have very poor compliance to patching rather than with atropine. So most of the children preferred atropine occlusion, that is a cycloplegic occlusion rather than patching. So in one of the prospective randomized trial, it was seen that when they compared the two groups, that is one group received about 6 hours or per day of occlusion therapy and with patching, and the other group received cycloplegic occlusion, that is they received penalization with atropine, one of topical atropine. So it was observed that 9% of the children in the atropine group developed reduced visual acuity of 2 lines or more than the fellow eye after 6 months of treatment. So this just highlights us that atropine is more, daily atropine is more could be quite dangerous than occlusion therapy. So a family of a strabismic child should be instructed the need for regular follow-up. So we should take vigilant steps to avoid this reverse amblyopia, and we should watch for a reversal of fixation preference with full-time occlusion and report, and we should ask the parents also to observe for this reversal of fixation. We should actually educate them and ask them to report it as prompt as possible. So usually iatrogenic reverse amblyopia, it can be treated successfully with judicious patching of the formerly better seeing eye or by alternating occlusion. And sometimes just simply stopping the treatment also can lead to equalization of vision. Then coming to the next part of my topic, that is mixed amblyopia. So as previously discussed by Dr. Keerthana and Dr. Naveed, this is the combination of the two amblyogenic factors. So usually a combination of anisometropic and strabismic amblyopia is what is seen here, and especially in partially accommodative isotropia and microtropia. So as you can see here in the flowchart, if there is a significant refractive error, that is anisometropia, a high bilateral refractive error, there occurs a sensory deprivation, and this can lead to strabismus, and which again can cause, these factors together can cause amblyopia. So as you can see in the picture below, the child is having isotropia, and when he wears glasses, that is, he's having anisometropia as well. So when his refractive error is corrected, but his strabismus is not fully corrected. But so even though he is being given the full cycloplegic refraction, there is some amount of strabismus which is uncorrected. So this is partially accommodative isotropia. So it is a combination of form deprivation and abnormal binocular interaction. And anisometropic hypermetropia is the one which is usually seen, and usually more than 1.5 diopters. So if it persists beyond 2 years of age, it can result in amblyopia. So clinically, mixed amblyopia is more severe with similar deficits of visual functions, and there is greater loss of visual acuity and contrast sensitivity, and there is actually very less of stereopsia seen. So that's it, ma'am. Actually, I think I've finished.
Thank you so much. Well done. Perfect, Dr. Asana. All right. So I will go over some slides regarding the etiology until the Dr. Hala becomes available. So I won't repeat what you have said. Sometimes there is a title in amblyopia called the mechanism. And you already mentioned the mechanism. So, for example, in refractive amblyopia, there is a consistent retinal defocus. There are some technical terms or like keywords here. And as Dr. Naveed mentioned, anisotropia causes unilateral amblyopia, while isoametropic causes bilateral amblyopia. And you may find the spelling for isoametropic in some reference without the A here, but I think isoametropic is more accurate. And this is again the most common form of amblyopia. And here there is some guidelines from the American Academy for the level or the threshold that you may expect the presence of amblyopia. So you have to know some numbers here. So they classify anisometropic amblyopia into anisohyperopia, anisoastigmatism, and anisomyopia. And here is the threshold here. So if you have an anisohyperopia 1.5 or more, you may suspect that this child has anisohyperopic amblyopia. And for astigmatism is 2 diopters, for anisomyopia 3 diopters. And regarding the isoametropic amblyopia, there is also another table for the degree of hyperopia. So from 4 to 5 for hyperopia, from 2 to 3 for astigmatism, from 5 to 6 myope. And as you know, myope, the numbers for myopia are higher because mild myopia, in mild myopia, the child can see at near. So this is why in some references you will see this sentence: the myopic patient are less susceptible to amblyopia than the hyperope, because in myope can see clearly at near, and that's why the numbers for amblyogenic myopia is higher than astigmatism and hyperopia. And again, we will see another numbers and another important table when we cover the lines of treatment, spectacles treatment in the next part of our talk. All right. Here is a question for you. We have 3 visual acuity charts. Forget now the one in green. So which is better, the one in blue or the one in pink? We have 2 types of chart here, the blue one and the pink one. Which is better when testing the visual acuity? Yes, Dr. Naveed, the one and the Keerthana is the one in pink. And why is that? What's the difference between the pink and from the blue? What is the meaning of crowding here? Because we have 1 optotype in the first, 2 optotypes in the second line, 3 optotype in the 3 lines. So the number and the spacing almost the same. So it's not between the pink and the blue, they are the same regarding the crowding. Okay, forget the green now. We differentiate between, we compare between the pink and the blue now. Which is better? And you said the pink. No, we are not using single optotype now, but we have a chart and we ask about the visual acuity. We ask the child about the visual acuity. What's the difference between this chart and this chart? There is one difference. Just look closely or you will find. Okay, forget the lines. Ignore these lines. This is ignore these lines. So Dr. Sana, put aside the green one now. What's the difference between the optotypes here and the optotypes here? For example, let's make it more specific. And here, let's have a pin here. What is the difference between this line here and this line here? Both are Landolt C chart. Both are 3. Yes, okay, Dr. Naveed, you got it. So here we have oblique presentation, representation of optotype. Here it is oblique. There is some optotypes where the opening is oblique. And what's the significance of this? So Dr. Naveed, you have to answer this question because your talk was about the refractive amblyopia. So suppose a child, like you notice that the child knows optotypes until 6-6, but he always miss certain meridian. So what's your diagnosis? Astigmatism. So link the astigmatism with the amblyopia. What we call this amblyopia. It has a specific term. Excellent, Dr. Sana. Is meridional amblyopia, and this is some form under the title of refractive amblyopia. And back to Dr. Sana. Dr. Sana repeatedly answers that the one in green is the best one, and this is the correct answer. The one in green is the best one. And why is that? Because you already mentioned, because there is some control over the crowding, because we have 5 optotypes in each line. And this, by the way, one of the logMAR charts, which is known to be the most accurate chart when documenting the visual acuity.
Because of constant spacing between the letters, and each line contains the same number of letters.
Excellent. Yes, this is the correct answer, Dr. Sana. Thank you. So if you find that the child always misses this, the optotype in this direction, this is the diagnosis of helps you to diagnose meridional amblyopia. Regarding Dr. Keerthana's topic about the vision deprivation amblyopia, so if you have a child who have like a significant congenital cataract, which is also a risk factor for amblyopia, in his chart or file, you have to mention the diagnosis. So the main diagnosis, of course, is the cataract. And you have to write in the consent or while counseling with the parents that there is also an amblyogenic risk factor. So we have here multiple diagnoses. We have dense visually significant cataract, for example, and we have a vision deprivation amblyopia. And this is, again, important when taking the consent before surgery and during counseling with the parents. And this should be also in your answer. If you ask about the management of congenital cataract, you have to clear the media. You have to provide the infant with the visual habilitation very early because the time is limited and the window for treatment of amblyopia, or the critical period for vision deprivation amblyopia, is faster. You have to be in hurry or provide those kids with urgent treatment because the amblyopia develops faster than other forms of amblyopia. And as Dr. Keerthana mentioned, it's very difficult to treat and it carries poorer prognosis if there is a delay in the treatment. And Dr. Keerthana mentioned a lot of causes. But Dr. Keerthana, some examiners may become unhappy when you mention the optical hyperplasia. So generally, you have to mention only the correctable causes of vision obstruction, like ptosis, like cataract, like corneal opacity, like vitreous hemorrhage. So generally, in most books or most references, they mention only the vision obstruction. But optic hyperplasia is already an organic cause that leads to diminution of vision. And unfortunately, it is uncorrectable. There might be a super added amblyopia, and we will cover this point in the next part. But generally speaking, from exam point of view, mention only these causes, ptosis and media opacities. All right. And it's not enough to mention cataract. As you said, you have to mention the early onset or congenital and visually significant. And as you mentioned, younger than 6 years. And some criteria for visually significant cataract, like in the central 3 millimeter. and we can check how we can visualize the fundus by direct ophthalmoscope and indirect ophthalmoscope. So we depend on objective signs to see if this cataract is visually significant or not. So by direct ophthalmoscope, if you see the fundus easily, so this child sees the visual, the space easily, or the surrounding easily. And also we can judge on the visual significance of the cataract by other than objectively by observing the pattern of fixation by this eye in unilateral cases, or if there is a secondary strabismus. So this may point to a visually significant cataract. All right. And again, cataract in the nodal point here. So as you know, from the sagittal section of the lens, this is the nodal point. So this is a visually significant cataract. And as Dr. Keerthana mentioned, the unilateral is worse than bilateral for the same degree. So if we have the same degree cataract, unilateral is more dangerous and more urgent to treat it than bilateral. And she already mentioned the timing for treatment. So she already mentioned 6 weeks for unilateral significant cataract and 2 months for bilateral. But pay attention that anteropolar cataract may have some optical distortion and anisotropia, and it, despite the fact of being a small anteropolar cataract, it might cause mild amblyopia because of the refractive errors. And you have to prepare for the causes of corneal opacity in pediatric age group. What are the causes of congenital corneal opacity or early onset corneal opacity? This is a case of Bitter's anomaly, and you have corneal dystrophies like CHED, congenital hereditary endothelial dystrophies. And regarding the vitreous hemorrhage, I remember that there was a question in one of our postgraduate qualification exams about the causes or the management of pediatric vitreous hemorrhage. It was a difficult question at that time because the candidates weren't prepared to answer such a question, because sometimes some questions you need to prepare it ahead before the exam. And here is 2 articles. I will post it in the video description about the causes of vitreous hemorrhage in pediatric age group. I advise you to go through them. All right. But by the way, can you mention only 2 causes or at least 1 cause of vitreous hemorrhage in a child? Okay, ROP, another cause, please. There are 2 important, ROP is one of them. Okay, tumors like retinoblastoma. Yes, traumatic, excellent. So we have a specific term for traumatic vitreous hemorrhage, like shaken baby syndrome. This is an important topic. Sometimes the exam, in exams, they ask specifically about shaken baby syndrome. You know, from medicine, from general medicine, whenever there is a bleeding inside any place, trauma should be one of the important causes you must exclude first, whether it is accidental trauma or induced due to child abuse, and this is very important, or like bleeding tendencies. And then you have to add specific causes like ROP, like retinoblastoma, as you mentioned. So again, you have to consider the timing. So like early onset vitreous hemorrhage and for longer duration and significant, this is an important risk factor for amblyopia. Even hyphema, if you have a total hyphema in an infant or a child, you have to urgently treat it because you fear of amblyopia. Again, belong to the vision deprivation amblyopia if you have a ptosis, like severe ptosis obstructing the visual axis or the center of the pupil, as in this case. So what do you think in this case? Does he, this is a boy, does he have an amblyopia in the right eye or not? What do you think? Why no, Keerthana? So we can't see the center, the corner reflection here, because you see the corner reflection here, but it's not there. So suppose this is the condition since birth. Why there is no amblyopia here?
Actually, his visual axis is still clear. It's not a complete ptosis. It looks like a mild ptosis, but if he looks straight, maybe you can see the pupillary reflex equally on both the eyes. It's hypotropic. The
Excellent.
eye is hypotropic. Maybe if
So,
this eye takes up a fixation, I think this will come into focus.
okay. So, thank you. So you pointed out that this is actually a pseudotosis. And if we cover the left eye, he takes up the fixation, and there is no ptosis. So actually, this is not a case of true ptosis, this is pseudotosis secondary to hypotropia. But because of the hypotropia, and this is a constant hypotropia on the right side, actually he has an amblyopia, but it is not, it is basically because of the strabismus, because of hypotropia. So he has an amblyopia due to the long-standing right hypotropia shortly after birth. So again, whenever you have a ptosis, you have to ask yourself, is it true? Is it pseudo? And it could be both. All right, so we come now to the next, the last one, which is the strabismic amblyopia. And again, Dr. Hala, are you ready?
Yeah, we are ready.
Okay, I will stop my share now, and you can share your presentation.
First, I would like to thank you so much for giving us this chance to study and to encourage us positively to work. Secondly, most important, your presentation, very, very, very supportive and very helpful. And sure, Dr. Mosu, to gather us all. I'm going to speak about Strabismus Amphibia. First, what happens when somebody has strabismus? By conclusion, either suppression or diplopia. Strabismic amblyopia happens when competitive or inhibitory interaction between neurons carrying non-visible input from two eyes. So two eyes have, because the two eyes are not aligned, so we have non-visible input. So how the eye will respond? The visual cortex will be dominated by input only from the fixing eye, with reduced responsiveness from the non-fixating eye. When the child, where his visual system is still immature, suppression will occur. But if in adults, diplopia will happen. A common example for this, constant non-alternating strabismus. It could be alternating, but it must be unequal. So in these cases, suppression will occur and the amblyopia will occur. What is the mechanism? Actually, to see binocular vision, we should get stimuli from both eyes. When there is a manifest deviation, the corresponding retinal elements are not aligned or directed at the same object. So what will happen? Visual confusion and diplopia. So because the visual system is still immature, so there is like adaptive mechanism. Suppression will happen, but that will happen only in the immature visual system till 10 years of age. In this diagram, it's showing the difference in case the eye is aligned or in case here the angle of deviation in each eye. And this is right isotropia without suppression, and here with suppression, and here with anomalous retinal correspondence. What is anomalous retinal correspondence? It's like the deviating eye will take part of the retina and assign it to replace the fovea. There are some features to distinguish Strabismus amblyopia from other types of amblyopia, grading acuity. We will find that such tests like Taylor acuity cards and layer grading cards that overestimate recognition visual acuity. And also in the neutral density filter, eccentric fixation. This is one example of common strabismic amblyopia. What will happen? It's like a part of the retina, it will be assigned to be replacing the fovea. How we will test this? By the visuoscopy.
These are the forms of suppression. We have physiologic suppression, and this is normal. And we have pathologic suppression, that is our case today. And it's the same, like I mentioned before, adaptation within the immature system to avoid diplopia, but provided that the patient has normal retinal correspondence. There are some types. There is the foveal suppression, the central suppression. The foveal image will not reach the consciousness. And the peripheral suppression, the cortex will not receive the image coming from the peripheral retina. And as we mentioned before, that is cortical adaptation and only immature visual system. This is the whole story of the strabismus amblyopia, because in adults they will get diplopia. I will mention some cases and how strabismus amblyopia happened. First case, monofixation syndrome. Monofixation syndrome, this is a case of a small angle strabismus. Even we can't notice, it's not manifest. But this child will be having a strabismus amblyopia. Okay, isodeviation, which is very, very common, 50 to even more than this. Infantile isotropia. Amblyopia is present. The better seeing eye will fixate in all field of gaze, making the amblyopic eye appear to have abduction deficit. And what we will do to know, we will do the doll's head maneuver. Another example, accommodative isotropia, frequently associated with amblyopia, and it has good prognosis with the treatment. Another example, basic acquired non-accommodative isotropia. This concomitant isotropia and occur in older ages than the infantile one, and not associated with the accommodative component. So it's in between the two types. Another type, a sensory isotropia. This sensory isotropia is considered a monoocular visual loss due to some causes like cataract, corneal clouding, or optic nerve disease, or so and so. What will happen? Sensory deprivation isotropia. So isotropia will happen, but because also this is immature visual system. In exotropia, premature infants with ROP, also higher risk of strabismus and amblyopia. Third nerve palsy also, sixth nerve palsy. That's all.
Again, thank you so much. I think you spent a lot of time making this detailed presentation.
Thank you.
So, always strabismus is a big topic, and I have like a strategic way regarding the strabismus. I always teach strabismus like bit by bit, because it has a lot to cover. So that's why I try to avoid speaking a lot about the strabismus. Since we have here a strabismic amphibia, I have to mention some points related to the strabismus. So I'm just saying is the points in the strabismus regarding our topic. So about topic is strabismic amphibia. And we mentioned last time that always remember this mnemonic S for S. So strabismus causing suppression. And we said that suppression to avoid diplopia and confusion. We said this last time. And mention visual confusion. So it's better to say visual confusion, because confusion has many meanings, so to avoid visual confusion. And we went over this schematic representation of diplopia and confusion last time. And as Dr. Hala mentioned, that which type of strabismus that has a high risk for inducing myopia, the constant non-alternating heterotopias. So if you have like a constant, like we have a right isotropia all the time, at near and at far, at right gaze, at left gaze, on every gaze, and always constant on the right day and night. So we expect that this right eye has an amblyopia. Sometimes we have a specific forms of strabismus under the heading of constant non-alternating squint, something called eccentric fixation, and Dr. Hala mentioned this one. And I will have some points about I will say some points about eccentric fixation because I already posted a picture of eccentric fixation on the WhatsApp group. Regarding the monofixation syndrome, it's a big title and it has a specific presentation. So one day, maybe next year, I will do a presentation about monofixation syndrome because it's important. And this is a common question if you are appearing to the ICO second part or ICO subspecialty strabismus subspecialty exam. And this is also important in amblyopia, but because it's a big title and there's a lot to cover in monofixation syndrome, I'm not going to talk about it today. So we have a constant suppression, we have a fixating eye all the time, we have non-fixating eye all the time. So this non-fixating eye develops amblyopia. Because I don't trust the speed of the internet, I will show you now a case of squint. And I will tell you what are you going to say because of the slow speed of the internet. So one by one. So my goal is not to enjoy the seeing strabismic patient because some have like an allergy regarding the strabismus. So in simple way, this is a snapshot. So here this is a freeze frame. Despite the fact that this boy is not looking straight perfectly, but as you see here, this is a right exotropia. So in this view, is this a snapshot, there is a right exotropia, right convergent squinting. So the right eye is the non-fixating eye, the left eye is the fixating eye. Okay, this is the first, this is the first line here, or this is the first point to notice here. Okay, so I want to make sure that you are following me. So whenever I say okay, you in your chat box say yes or okay. Okay. So whenever we have now a right exotropia and the left is fixating eye, I want to know if this right XT, so XT is the abbreviation for exotropia. So let's write it here. So we have XT in between brackets OD. So in this look, in this gaze, and this is in primary position. And ignore now whether the patient is looking at near or at far, ignore this point at the moment. So in the primary position, we have right eye shows XT. And I want to know, is it all the time? Is it all the time right XT? Or does the child alternate? What does it mean? Does the child sometimes fix by the left eye? Sometimes he fixes by the left eye or right eye. So how can we differentiate between unilateral constant strabismus from alternating? So we need to use the cover test. We need to use the cover test. So we will cover which eye? We will cover the fixating eye. And here is the fixating eye is the left eye. So what's happened here? Another snapshot. What's happened? By the way, I slowed down the video to make it very slow and to make it clear. So now I covered the left eye. And what's happened? What happens? The right eye takes the fixation. So here, the right eye takes the fixation. And this is good, by the way. So sometimes we will see later on that despite covering the fixating eye, this eye doesn't take fixation. But here, he was able to fixate by the right eye. So this is the second point here. So the second point here that the right eye, which was initially exotropic, is able now to take the fixation when the left eye is covered. All right? Now, what's the next step? The next step is to remove the cover, to remove the occluder. So once we remove the occluder, the child switched back to the initial misalignment. So the right eye again shows the divergent squint. So in summary, this child shows right divergent squint. He is able to take the fixation by the right eye only when the left eye is covered. But once we remove the occluder, the misalignment again back to the right eye. So the right eye always shows the exo deviation under binocular viewing. So as long both eyes are open, the right eye shows the divergent squint. So this is right exo deviation or alternating. This is a unilateral or alternating. So this is my question for you. Is it a unilateral exotropia or alternating exotropia? So again, it's excellent. This is a unilateral. So why Hala, doctor? This is not alternating. This is a unilateral exotropia. Again, this is a unilateral exotropia. So to summarize again once more, because I got not all the answers are correct here. In unilateral squint, like in this case, right, exotropia, it doesn't take the fixation except if the left eye, the fixating eye, is covered. But once you remove the cover from the left eye, again, the right eye shows the exo deviation. So this child all the time, as long as both eyes are open, the right eye shows exo deviation. So again, this is all right. So we expect now the right eye has an amblyopia, and the name of the amblyopia is strabismic amphibia. Okay, let's move on to the other type. So what do we see here? According to the Hirschberg, here the reflex here is descender temporally. So this right eye is isotropic. So this is my cases, so I already know the diagnosis. So I am saying the diagnosis. So here, this is a right isotropia. In this position, in this primary position, in this gaze, there is a right iso deviation. And again, let's write it here. So the abbreviation for isotropia is ET between brackets OD. All right. So what is the next step? We will cover the fixating eye, which is the left eye. So once we cover the left eye, which is the fixating eye, the right eye takes up the fixation. And this is good. Again, this is good. The right eye takes up the fixation. What is the final step here? To remove the cover from the left eye. And what you see now? Here, in this case, the left eye shows the isotropia, and the right eye stays holding up the fixation.
So as you can see here, the left eye shows iso deviation. This means that this is an alternating strabismus. So it could alternate between both eyes. The right eye could be isotropic, the left eye could be isotropic.
So back again, I hope you now can able to differentiate between the unilateral and alternating strabismus. Simply, you need to use the cover test, and this is one of the uses of cover test. and in the future, inshallah, I will do a course regarding strabismus course, and you will see that we have a number of cover tests. We have different techniques for cover test. And now you already watched one way of doing the cover test to differentiate between the alternating and unilateral strabismus. So in summary, to differentiate between unilateral and alternating strabismus, you decide first which eye is the misaligned eye, then you cover the fixating eye to see whether the misaligned eye takes the fixation or not. If it takes the fixation, you remove the cover from the fixating eye and see if the strabismus switched back to the original condition or it becomes alternate. I hope it's clear now. I don't know, but I repeat myself too many times. And this comes with practice. This comes with practice. So if you have a misaligned eye here and a fixating eye, you cover the fixating eye. Hopefully this eye will take the fixation. If it does, if it takes the fixation, remove the occluder from this eye and see what is the situation. If the initial misaligned eye remains the misaligned eye, this is a unilateral. If it is switched between both eyes, this is alternating. All right. Now, how about eccentric fixation? So if you remember, I posted this slide a few days back, and I got a correct answers. Most of the answers are correct. So I've taken this picture from the Strabismus simulator. This is a wonderful website for beginners. So the images here or the pictures from the Strabismus simulator, but I did some modification. So as you see here in the first picture, so what do you see here? The left eye is the fixating eye, simply because the Hirschberg reflection here is central. This is simply. But here the right eye, the Hirschberg reflection here is decentered temporally. That means that the right eye is isotropic. So we have a right, apparently this is a right isotropy. Alright, this is a right isotropia or right convergent squint, and the reflex is decentered temporally. And also roughly, when we see the reflection on in the edge of the pupil, this means that the angle of the strabismus is about 15 in degrees. If we can convert it to prism, it's about 30 prism. All right. So this is a significant amount of strabismus here. When we talk about 30 prism diopter, this is a significant. It's not a microtropia, because someone on the group said it is a microtropia. So this is not a microtropia, because by Hirschberg, the bireflection is around 30 prism diopter. And microtropia, something less than 10 prism diopter. So in this primary position, the right eye is isotropic. So what's next? We cover the fixating eye, which is the left eye. But here, the right eye doesn't take the fixation. So as you see here, despite covering the fixating eye, the right eye doesn't take the fixation. And my question is, what are the differential diagnoses, or what are the causes for such condition? Since you already answered in the group, one of the causes is something called eccentric fixation. And this is the definition of the eccentric fixation, and I will show you the definition in schematic representation. So I did this schematic representation to make it clear. So here is the marker here. This is the right eye, the isotropic eye. And this is the left eye, the fixating eye. All right? And I'm asking the patient to look at the near target. Because once we draw a target, this is a near target. And the eye should be slightly converging to see this target. So the left eye here is fixating on the target, and the image of the book here in the fovea. So this is an aligned eye. This is a perfectly aligned eye. But the right eye here is converging, has a convergent squint. So the eyes goes in, misaligned, and moves in. So the image of the book actually falls nasal to the fovea, because this is a misaligned converging eye. And I think we went through this image before when we discussed the diplopia in the previous part. So what's the next step? The next step, we cover the left eye. So we cover the left eye, and the image of the book here falls on the nasal to the fovea. But in patient with eccentric fixation, who has eccentric fixation, this area, which we call it non-foveal region. So this area is called non-foveal because this is the fovea, and this is non-foveal, logically. So this non-foveal region takes up takes the function or the job of the fovea. And the patient will tell you that I see the book, I see the target, and he points to the target, but actually he is not using the fovea, he is using a non-foveal region. And that's why it's called eccentric fixation, because normally we have centric fixation. Centric means fovea, but eccentric fixation means non-foveal region. So since this area functions as the fovea, there is no need to move the eye. There is no need to move the eye because this area already takes the function of the fovea. So again, this is the definition of the eccentric fixation, is the consistent use of non-foveal region of the retina during monocular viewing. So be aware of these keywords. It should be, the other eye should be occluded. In order to diagnose eccentric fixation, the other eye should be occluded, and this eye will not take the fixation. So initially, to diagnose eccentric fixation in a patient with strabismus, once you cover the fixating eye, the strabismic eye doesn't take the fixation because the point in which the image is falling function as a fovea. All right? Okay, Dr. Keerthana, anomalous retinal correspondence, which actually was an answer given on the WhatsApp group, and actually it's the wrong answer. This is a kind of visual adaptation, and each kind of visual adaptation has a specific test to diagnose. So in order to diagnose eccentric fixation, as I said, you have to cover the fixating eye, and the strabismic eye should not move, and the patient will say that I am fixating, okay? And we will verify the eccentric fixation by visuoscopy. But in order to diagnose anomalous retinal correspondence, both eyes should be open, and it has specific tests to diagnose. And again, this is a lengthy topic, and it needs a special dedicated presentation. So ARC is something, and eccentric fixation is another thing. It's confusing, I know, but make it simple. Concentrate now on eccentric fixation. So once more, in order to diagnose eccentric fixation, we have to do two tests. The first test is a cover test. You cover the fixating eye. The misaligned eye will not move, despite the fact the patient is seeing. So you ask the patient to mention the optotide, for example, the direction of the optotide, and he is saying, I see this, I see this, I see this, but the eye is still misaligned. And the second test to confirm the presence of eccentric fixation is by something called visuoscopy. And Dr. Hala said the visuoscopy, and visuoscopy is simply, if you check the direct ophthalmoscope, we already have direct ophthalmoscope. One of the options or the mirrors, we have like filters here. There is a filter in the form of a star or in the form of cross. So visuoscope is not a specific instrument. It is an option in the direct ophthalmoscope. So in order today to confirm the presence of eccentric fixation, you cover the, again, you have to cover the fixating eye, and you use the direct ophthalmoscope to observe the fundus of the misaligned eye and ask the patient to fixate on the star in the light. And you will see that the star is not coincide with the fovea. It is eccentric to the fovea. It is nasal to the fovea if it is an isotropia, or temporal to the fovea, it is an exotropia. So visuoscope is not a specific instrument. It is an option in the direct ophthalmoscope. And again, I shall make a presentation about the visual adaptation on strabismus, in which we will cover all the headings Dr. Hala mentioned about suppression, diplopia, ERC, eccentric fixation. Lovely topic. All right. So in summary, patient with eccentric fixation, when you cover the fixating eye, the misaligned eye will not move because he already using this eccentric point as a fovea. And that's why I said eccentric fixation by cover test, and then we need to confirm it by visuoscope. Another differential diagnosis for this situation, when you cover the fixating eye and the right eye doesn't move, maybe because there is a dense amblyopia here. And this is common in unilateral dense amblyopia in infant. You cover the fixating eye, and for example, the isotropic eye here doesn't take the fixation. So you suspect that this eye has a dense amblyopia. And you already mentioned this as a differential diagnosis on the WhatsApp group. So that's why Dr. Sana mentioned blind right eye. Not necessarily blind, but dense amblyopia. We can say dense amblyopia. And someone here said, Dr. Naveed mentioned something important, and actually this is one of the differential. I don't know why you said sorry after this answer. This is a good answer. Why you are sorry? Simply, the eye doesn't move because this is a kind of incompetent strabismus. The eye doesn't move because either the lateral rectus is paralyzed, because we need to abduct the eyes, right? To abduct the eye. So either the lateral rectus is paralyzed, or there is entrapment, as Dr. Naveed mentioned, in the medial rectus, right? Like restrictive. So it could be restrictive or paralytic squint, prevents this eye from moving. And another important point also, negative angle kappa, and I really love pseudosquint. Again, I shall make a presentation about pseudosquint. So there is something called angle kappa. Normally the reflection is the center or slightly nasal, but sometimes we have something called negative angle kappa normally. So the reflex is instead of being decentered nasally, it is decentered temporally, and it gives us a pseudo-convergent squint. So it could be a non-squint case due to negative angle kappa. And the last one is an inattentive or uncooperative child or whatever. So this is the list of the differential diagnoses for having such situation. And since eccentric fixation, one of these, you need to confirm everyone by additional steps. So so this situation is not pathognomonic for eccentric fixation. That's why we need the visuoscopy to confirm the eccentric fixation. I hope it's clear now. Here is the screenshot of your answers on the WhatsApp group. You already mentioned the sensory or like poor vision or amblyopic vision. You already mentioned eccentric fixation. Here, one of my colleagues, but nobody mentioned negative angle kappa, which is really important cause. And here we have two wrong answers here. This is not an ARC. So ARC diagnosed binocularly, while both eyes should be open by specific test. And this is not a microtropia, because microtropia by definition, the angle less than 10 prism diopter, 10 to 8 prism diopter. And here this is a significant isotropia. And again, every rule has its own exception. So this is one of my patients, and this is the primary position. He has congenital third nerve palsy on his right eye. His right eye is exotropic, hypotropic. It's long-standing since birth. So what do you think? Do you expect poor vision in this eye? It should be, because this is a constant, so as you already mentioned, constant, non-alternating strabismus, and Dr. Hala mentioned congenital paralytic third or sixth nerves, right? So you expect there is an amblyopia. But ironically or paradoxically, this right eye has 6/6 vision. It's even sharper than the left eye. Because he already have a unique visual adaptation. The fovea of this eye is seeing the temporal field, and it happens. The important of mentioning that amblyopia, in order to diagnose amblyopia, the hallmark here is to assess the visual acuity. All we have mentioned about the risk factors, they are risk factors, but we should measure the visual acuity. Once we are able to measure the visual acuity, we should measure the visual acuity, because this is the hallmark for diagnosing amblyopia. All right, and this is a nice quote here. There is no exception for the rule, or to the rule, that every rule has an exception. Okay. So my aim to have a wonderful meeting experience, and that's one of my aims. But actually, it needs time. So again, monofixation syndrome is an important topic, so you have to study it by your own until I can make a presentation about it. And here, Dr. Sana mentioned everything about mixed. And I really like her presentation, because she went through articles to read about it. She said it regarding the reverse or occlusion amblyopia, it can occur with patching or atrophy in eye drops, or it could be both. So don't forget combined. So I really like to mention combined. And since we induce this amyotropia, despite the fact it is accidental, this is called iatrogenic. Sometimes they call it iatrogenic because it is a result of treatment. And something came to my mind right now, that sometimes we offer the patient a patch, and they patch the amblyopic eye. I don't know if you faced a case like this. Sometimes parents patch the amblyopic eye. That's why we have to stress which eye to be patched, right? And this is a question I posted on WhatsApp. So which is better? So if I ask you this question, if you have a child, suppose you're a child, or your younger daughter or brother, or even you yourself, if you have a choices, which one to choose, to have an alternating strabismus or to have unilateral strabismus, which one you would choose, and why? So alternating is a good answer, and I guess because alternating, there is no risk of amblyopia. Although Dr. Hala mentioned sometimes it's alternating, but the right eye most of the time is the squinting eye, so we may expect some amblyopia in the right eye. It is alternating, but the right eye has the upper hand to have this, to show the strabismus. So sometimes alternating strabismus have amblyopia on the eye which is mostly misaligned. And alternating also has good vision, so it has the same meaning. So in alternating strabismus we expect nearly equal vision, we expect no amblyopia. And this is a good answer. And what is the perfect answer? So if someone asks me if you would choose what we would choose, I will say this answer at first. I would choose neither, because both are bad. Nobody wants to have a strabismus, right? Because even alternating, despite the fact of being equal vision, no amblyopia, they don't have binocular vision. They don't have binocular vision. So this is one of the big problems in strabismus, that they don't have binocular vision. But of course your answer is the correct answer at the end, because unilateral there is a risk for amblyopia. So whenever someone asks you to choose between two things bad, you should answer first, I would choose neither. And this is also works for life, in anything. So here is the next question. If you have the choice to choose between strabismus and anisotropic amblyopia, which one would you choose for you or for a child? Excellent, Dr. Naveed, neither. So you got the lesson. Okay, neither. But this is incomplete. So you can say I would choose neither, but if I have no other option, I would choose what? Which one is better? Generally, because again, every rule has its own exception. So I would choose strabismus or anisotropia. Generally, we can answer by choosing anisotropia, because anisotropic patient have something called peripheral fusion. They may have some fusion, they may have some striopsis better than the strabismus. All right, so I would choose neither, but if I have no other choice, I would choose anisotropia because they have peripheral fusion. But remember that there is some type of strabismus which is monofixation syndrome. Again, monofixation syndrome, they have some fusion. Okay, here is the other side. If someone asks you to choose between both good conditions, like to have what I can think, you have a big salary, or we will offer you a free luxurious car, what would you choose? So if someone asks you to choose between two good things, you will answer by, this is a question, both. Excellent, Dr. Naveed, you got the message. So you can start your answer by both, but again, you may look as a greedy person, so you can end up your answer by choosing one. All right. This is a slide, this is another heading in the amblyopia called the mechanism. So in strabismus, there is unilateral constant strabismus. The mechanism for amblyopia is suppression. In refractive, if it is unilateral like anisotropia, we have two mechanisms: suppression of the anisotropic eye and something called image degradation. You mentioned it, or the other name for it, pattern distortion. But if it is isoametropia, the mechanism for amblyopia is only pattern distortion. In vision deprivation, if it is unilateral, so there is suppression from this affected eye in addition to pattern or vision distortion. But in bilateral, we have only pattern distortion. So what do you notice here? You notice that whenever we have a unilateral cause like strabismus unilateral, or anisotropia, or unilateral vision depression, the mechanism should be suppression. should be suppression of the affected eye. So the message here that suppression doesn't only happen in strabismus. Suppression doesn't only happen in strabismus. It could happen for other causes like anisotropia or unilateral vision deprivation. Because some beginners think that suppression happens only with strabismus. All right. Hooray, we finished the etiology. All right. And actually, we are behind the schedule. And again, I don't want to overwhelm you. And I think we can stop at this point. But we can end our presentation by quiz time. It's a quick quiz. Again, you can read it by yourself and answer. I got the right answer from Dr. Naveed, and this is from a book. And by the way, sometimes this appearance of capillary hemangioma looks like a child abuse or like trauma. So sometimes vascular regions looks like stroma or hematoma. Sorry. This is an excellent book called Provision, and what's unique about this book and that every series, every edition has its own questions and answers. So it's an MCQ and in form of clinical problems, and they justify the answer. So let's see here, Dr. Sana, can you please, Dr. Sana, read this slide? So can you please read the justification of the answer?
Yes, ma'am. This child has the typical history and physical findings of orbital and adnexal capillary hemangioma. These tumors may cause unilateral astigmatism by compressing the affected globe, which may result in an isometropia and secondary amblyopia. Enlargement of the lid portion may occlude the visual axis, causing deprivation amblyopia. Enlargement of the orbital portion may interfere with the extraocular muscles, nerves, causing paralytic or restrictive strabismus and secondary amblyopia. Symmetrically large refractive errors of both eyes, which cause isoametropic amblyopia, are not associated with hemangioma.
Thank you, Dr. Sana. Thank you so much. So as you see here, it could be combined. So we have many factors. We have a factor that cause anisometropia, factor that cause deprivation, factor that cause strabismus. And also management of capillary hemangioma is an important topic in practice and from exam point of view. All right. Then we have 3 quizzes. The second quiz is taken from a lecture from the American Academy for Resident. Which category of strabismus is associated with highest risk for amblyopia? Excellent. So it's 2. The last one. A 6-year-old patient with blurred vision found to have psychoplegic refraction of +7 OU, and the best corrected visual acuity is 20/40. The most likely etiology for bilateral decreased vision is So do you know what is the meaning of convergent disorder? So we as a human have a tendency to choose what's unknown, right? So convergence disorder is the other name for convergence disorder is hysteria. Simply, this child has a high refractive error, which is +7, and we already mentioned that this is beyond this threshold, and this is a risk for amblyopia. So despite he is giving the correction, he has an amblyopia, and this is Dr. Naveed should answer this one. This is isoametropic amblyopia. So this is why we have to link the gap between studying the theory and having an MCQ or clinical problems. We need some connection. So this is a translation of what you have said, that if you have a bilateral high refractive error and this causes isoamytropic amblyopia. And again, convergent disorder, it is a psychological disorder. I forget to mention here in this question, why in this question he mentioned the child is healthy, eating, gaining weight, because if we have an proptosis in a child, the most common cause for proptosis is orbital cellulitis. So he's trying to exclude the orbital cellulitis. So the common is common, and maybe he is also trying to exclude retinoblastoma, as Dr. Tamana mentioned. So I shall make it now it's 4-part presentation. So because we didn't go through the diagnosis yet, so the next part will cover the diagnosis. So we will have 4 parts for amblyopia, and it deserves, right? I think it deserves. It seems like a short topic, but it's branching. It's lengthy indeed. So our next meeting will be, inshallah, next Sunday at the usual timing, 6 p.m. India timing. Again, the same request, if you have a case of amblyopia, please share it on the WhatsApp group. Stay active, stay alive, and study attentively, and keep learning.